Hello and welcome to this webinar about legal and professional aspects around vaccine administration. Thank you for giving up your time to watch this webinar and I hope it's useful for you. So I am Alice, I'm a registered nurse and immunisation tutor with a specialism in travel health. I also teach phlebotomy as well. If it involves stabbing someone in the arm with something, I'm usually there teaching it. And I do face-to-face and Zoom sessions all around the UK. So I have a really good opportunity to see what kind of things are going on in different practices around the place and pick up on questions that people are asking and situations that people end up in. So I'm going to present this course as a kind of scenario-based teaching method because with some actual examples of things that go on in practice and things I get asked about. Now the title of this course, Should I Be Doing This?, is quite deliberate because this is the kind of question I get a lot in courses. Questions that start with, should I be giving this vaccine? Should I be going to do an offsite? Should I have a doctor nearby? Can a HCA do this vaccine? Can a nursing associate do that? These kind of questions are really, really common, and sometimes they're not a very simple yes or no answer. So I'm hoping that this webinar will help to address those kind of questions in a bit of a longer way than just a yes or a no answer. So let's dive right in. As I said, everything that this course is based on is stuff that's come up in either clinics I've been working in or courses I've been teaching on. So we're going to first start with clarifying who can do what with regards to vaccines, mainly looking at the distinguishing features between registrants and non-registrants, but also some of the grey areas in the middle. And then we're going to look at competencies in immunisation and minimum training and supervision standards as well, which go very much hand in hand with each other. We're then going to look at probably the most exciting bit of the course, which is around freedom of speech and professional implications. And we'll look at an example of a nurse who was struck off for, well, a midwife, for her expressing her views in a certain way. And then we'll finish on informed consent around vaccines, really as the cornerstone of any vaccine administration. And we'll look at some of the nuances there and the things that people tend to struggle with. So firstly, before we begin, this is quite an important document that has just arrived in the last month or so, as when this is being recorded anyway, published on the 13th of December 23 and updated 4th of January this year. So this is the NHS vaccination strategy, which sets out a load of proposals about how they see vaccination going and some of the aims that they want to do to make it a more effective programme. So here's an excerpt from one of the proposals there, to help make vaccination the business of everyone working in patient-facing roles through training and awareness campaigns and widening the roles that can vaccinate to increase the number of vaccinators. So for the purpose of the course today, this bit really piqued my interest because it's about widening roles and making it the business of everyone, which is fabulous. I think there should be a lot more training around immunisation in all kinds of job roles. So this is great as long as it's done properly, and they don't really allude to how they're doing that, but there's also further information that they give on the next slide. Here are some of the other things they talk about. Developing a workforce with a skill mix that makes best use of trained, unregistered staff where clinically appropriate. They talk about wider use of the national protocols as well. So these were introduced in the pandemic to try and divide up tasks and increase the workforce, giving this mass vaccination campaigns of COVID and flu. And a large part of it has worked very well. And so it looks like the national protocols are here to stay. And I wonder if maybe they will be expanding them even more. We're in the middle of a measles crisis right now. We've had monkeypox outbreaks. There's potentially an RSV programme on its way. So are we going to see this used a bit more for other mass vaccination campaigns? Who knows? Your guess is as good as mine. We also in here it says explore options to revise regulations, and earlier on it talks about legislation as well. So could there be some law changes potentially around delegation? And this is interesting. We're going to talk about delegation shortly there. There's not a lot of ways around this, but we can talk about that. And then the very last point on this slide is to work with Royal Colleges, GMC, other relevant bodies to explore how they can make vaccination part of foundation training. And this is music to my ears, really, because I think traditionally it's something that you go on to do after you've trained, and it's a specialist thing you do later on. And this was always how phlebotomy was perceived as well. And now phlebotomy is entering foundation training, pre-registration training as a basic training thing. So I think this could be a really good plan as long as it's implemented correctly. I think it's everybody's business to be able to talk about vaccines. It's a very important and topical field, and often a topic of conversation down the pub as well. So, and we have to be mindful of how we talk about vaccines as health professionals, as we'll see later. Apologies for the continuity issues. I have since removed my glasses because there was a lot of glare on the camera. So, who can do what? Registrants versus non-registrants. So vaccines are prescription drugs, and they are subject to legislation, of course. We're going to be very careful about when we give them. Ultimately, though, the task of giving an injection, the physical administration of an injection, is the same task whoever's performing it. So whether it's a doctor, a nurse, a HCA, if they're trained appropriately, everybody will be doing the same thing. The task itself, the actual physical thing, is always the same. So technically, anybody can administer a vaccine as long as they're well trained. The differences between different professions and job roles is what comes before that administration. And it's always to do with assessment of whether somebody's eligible, what the side effects might be, what the contraindications might be, and the just general assessment of risk and the benefits of this vaccine for that person. And then sometimes it's not just what comes before the administration, but what comes afterwards. So if somebody was to have a severe adverse event, for instance, like anaphylaxis, there's also assessment involved in that too. And that's another area where there's differences between what different professions would feel competent to deal with at that point. But really the crux of it all is that assessment is the key here, and between all of the different roles, the autonomy in the decision making and the accountability of the professional that's making those decisions. So we're going to look at some examples now of a role that has stimulated a lot of confusion. We're going to look now at the differences between a nursing associate and a registered nurse. Now, this role is a fantastic role. It was introduced a few years ago as a bridging role between HCAs and registered nurses. But I think still sometimes people are a little bit confused with how far this role goes and where it does actually differ from nurses and from HCAs. So the next slide will look at the differences with HCAs, but this slide will look at the differences with nurses, registered nurses. So we can see a lot of similarities on this slide. You can see that they are both expected to be accountable to the NMC Code of Practice. They are also highly influential in promoting health and preventing ill health, which is perfect venue for a vaccine to pop up. Vaccines are one of our greatest medical interventions for preventing ill health. So awesome role in vaccines there. We've got both professions who provide care and work in teams, but there's subtle differences there. So the nursing associate would perhaps provide care that's already been put in place, and a registered nurse is someone who's evaluating and putting in place those care plans. So in the context of vaccines, that might be that the registered nurse can do that assessment at the beginning to make a plan for that particular patient, and then the nursing associate can then administer the vaccine under certain laws, which we'll talk about later. The working in teams is slightly different as well. It's very much expected that a nursing associate works as part of a team, and they have a wider team around them, and they're supervised and supported. Whereas registered nurses often work alone, or they are involved in managing that team and coordinating that team. We've got similarities completely with improving safety and quality of care, which of course is to be expected. Then we've got this gaping hole at the bottom where assessing needs and planning care comes into it. So this is the crux of the differences here. And when we apply this to vaccination, we could assume that in this case, with vaccinations, this would mean the assessing for eligibility, assessing for contraindications, and so on. Now, ultimately, there's always going to be an element of assessment for any person giving a vaccine. They don't just do it blindly. And the reason we cover diseases and stuff on courses and we talk about the vaccines is because anyone who's administering a vaccine needs to know stuff around that vaccine. So a lot of the time nursing associates would be double checking a risk assessment, or they may be doing a risk assessment and getting someone else to agree with that risk assessment. But there's still going to be that element of a nursing associate is not expected to do this on their own. And these distinctions could easily apply to physicians associates and doctors, or pharmacy techs and pharmacists. There's all kinds of different roles, and I think this really helps to illustrate the differences there. So we've looked at the differences between registered nurses and nursing associates. And now we're going to look at the difference between nursing associates and healthcare support workers. So there's two key documents that the RCN have produced. And the RCN have produced guidelines. And I must stress these are guidelines and recommendations. It's not the law, but it's what the RCN views as appropriate for people's roles. So it's very obvious immediately from just the title of these two documents where the differences lie. The RCN specify that they support healthcare support workers to give shingles, pneumococcal and the flu vaccines. It's even in the title. They describe which ones they're happy for HCAs to be part of. Whereas in the role of the nursing associates document, they don't specify at any point which vaccines they're technically happy with nursing associates doing, which just broaden the role for the nursing associate. It means they can get involved with different types of vaccines, which is great. But they do still have some barriers to this, namely, again, the assessment of patients and stuff. I'm frequently seeing nursing associates on courses who are running full childhood clinics by themselves or travel health consultations, which is slightly worrying because then they're put in a position where they're doing an awful lot of assessment and by themselves. Now, the NMC opinion, of course, is the same as the RCN's opinion, and they state in there that the role, although it's evolving and will differ between organisations, is very much seen as a role that's part of a team, and that if a nursing associate is working under PSD, which they would be in this case, then they need to have their prescribers nearby and they need to have the support there, as well as things like indemnity insurance and relevant governance procedures as well, and policies and all of that stuff. So it technically means they've got a broader scope of vaccines that they could be involved in, but they still got to follow the same principles that a HCA would, in that they can't be too involved in that assessing side, unsupervised or unsupported. Here's an example of something that actually does come up a lot on courses. This is nursing associate Sarah. She turns up on a 2-day foundation immunisers course for registered nurses, and she's been told that once she's done the course, she'll be able to take the lead on all of the childhood clinics from then on, working independently under PGD. I hope that reading this, you have already spotted some of the issues with this. But if not, here's what they are. So firstly, this nursing associate is put in a position where they're doing an awful lot of assessing here. And there's an awful lot of independent work going on. The nursing associate legally can't work under PGD. Nursing associates and physician associates are not currently included within the legislation, so they can't operate under PGD. Plus, for a nursing associate working to a PSD, the registered nurse or registered prescriber should always be immediately available so they can respond to any queries or problems which fall outside of the scope of practice and the knowledge of the nursing associate, and that's stated in the RCN doc that we just looked at. So how practical then is it for a nursing associate to be getting involved with the childhood vaccine clinics? That's my question. The other thing here is that expectation of completing a course and being ready. And we're going to talk about that later when we talk about training. But ultimately what this case illustrates is that we really have to respect those legal boundaries, despite how competent Sarah in this situation might be. She might manage those clinics really, really well, but we've got to think about those legal boundaries within the role as well. Here is Martin. Martin is an experienced HCA. He's worked at the surgery a very long time and he's a real asset to the team. The practice manager decides Martin might as well expand his role and they make him the immunisation lead for the practice. The practice manager also instructs him to do some off-site flu clinics by himself in a local sports hall. He is, after all, very competent and knows the job inside and out. It's surprising how often I hear about non-registered staff going to do off-site visits on their own with no supervision. This is a bit of a worry because whilst they can absolutely manage that situation, I'm sure they can go to an off-site, do exactly the same as they do in the surgery and administer vaccines under PSD and all of that, fine. That's okay. But the question to ask here with Martin is, what would happen if something went wrong? Martin would then be put in the position of having to do things like potentially diagnose an anaphylaxis, plan care for a critically ill patient, and then implement it all by himself. And this isn't really his role. This is way beyond the scope of his role, even if he's perfectly competent to do it. Now, this is where confusion arises too, is that healthcare assistants can get involved with any part of the BLS situation. So they can do the rescue breaths, the chest compressions, they can give adrenaline under the law because it's exempt from prescription in the legislation for the purpose of saving a life. So he can do all of those components of BLS. But what he's stuck with if he's on his own is diagnosing, planning care and assessing patients and then evaluating how it's going. So it's all of those words that were in the nursing associate comparison earlier, they're popping up again here because he's then put in that position and it's in a very stressful situation. So really it's not, I do get asked a lot, can HCAs go and do a vaccine clinic off-site? Although the answer on the surface might be, well, yes, it's the same as what they do in the surgery. The thing to ask here, the right question to ask is, can they deal with an emergency if it comes up, and would that be a comfortable position for everybody involved? And also, would the insurance cover Martin to expand his role in that way? The other thing it's happened with Martin is he's been too good at his job. Never be too good at your job. Obviously do a good job, but don't be too good at it. Because this kind of thing happens. People start giving you more jobs. And he's been made the immunisation lead for the practice. And again, those words come up. Immunisation leads are often involved in managing a team, coordinating care between team members, dealing with adverse incidents and complaints and writing new policies and plans to make things better. And whilst again he probably could deal with some of those things, it is not his job role to be doing those things. It's too much responsibility for a HCA. So here's another case. So this is assistant practitioner Daisy, who is very frustrated that despite her experience, she is still being told she can't do childhood or travel vaccines. She's bored of flu, pneumococcal, shingles. The RGN, who's working under PGD, feels sorry for her and lets her give a few hepatitis A and meningitis B vaccines under her supervision. Now, this kind of thing happens a lot with student nurses too. The crux of this is that you cannot delegate under PGD. It's different for non-injectable medications, but for the large part, most vaccines are given by injection. And these ones are, of course. So she shouldn't really be delegating under PGD. That's an illegal administration of a vaccine. The whole task must be completed when you're working under PGD. Now, this is where national protocols differed because they did divide up the tasks and allowed people to do different parts of the process. But that was that legal mechanism. And at the moment, we only have those for COVID and flu. So I do really sympathise with APs. I see a lot of very frustrated assistant practitioners, especially since the nursing associate role came along. I do sympathise. There's a lot of incredibly experienced and very valuable APs out there. But again, they are constrained by the boundaries that their role imposes on them. And in this case, the law. Here is another example, Sandra, of somebody who perhaps doesn't understand the laws around PGDs. So she always works under PGD for all the vaccine clinics, but she's never really got to grips with how this should be used. So she often goes off label or off license without getting a PSD first, treating the PGD as simply a bit of useful guidance. She's often heard saying, "It's not the law, is it?" Well, Sandra, it is the law, unfortunately for her in this situation. Now, I'd never discourage anyone from using their clinical judgment and going off piste, as long as we do it through the correct legal mechanisms. So if you do need to deviate from a PGD, it's going to get that PSD before you do anything else. That's very important. And she's not wrong when she says things like, guidance is something you can deviate from. I mean, all of the guidance that we've got is just that, it's guidance. And that is something to be interpreted perhaps locally, but not when it comes to PGDs. For someone like Sandra, who isn't really clear on her role when it comes to working under PGD, I would certainly recommend certain competencies that she might go and complete, and also guidance that she might read around PGDs. So for instance, NICE have produced some really good guidance about working under PGDs and what it means. And there's lots of other competencies in immunisation as well. So we've got the RCN publication, which is all based on the national minimum standards for anybody giving injections and immunisation. And within this document, there's two sets of competencies, one for registrants, one for non-registrants. So that's a really good place to start when somebody starts immunising. Then, of course, there's the PGD competencies and working under them. So if I had a team, I would make sure that everybody working under PGD had signed these competencies. And then we got two wonderful publications in travel health, if that's part of your role. So we've got the Good Practice Guidance, which is the Royal College of Physicians and Surgeons, Glasgow. This came out very unfortunately timed, really, because it came out just as COVID came out. And the lockdowns happened and no one was travelling and everybody forgot all about travel health for a bit. So it was unfortunately timed, and it has slipped through the net for a few people's, it went sort of into the periphery. But definitely have a good read through that document if you are doing travel health. Within there's 11 pages of competencies, not all vaccine related, because of course travel health is not just about vaccines. That is just the tip of the iceberg, really, when it comes to travel health. We've also got this other document, the RCN Travel Health Nursing document, which has been around quite a while, longer than the other one. However, it has just been updated in May last year, so it's well worth revisiting those competencies just to check that you're still happy with everything that's expected of you if you're performing a travel health role. There's also, within all of these documents, there are further recommendations for other types of mandatory training. So for instance, in the immunisation competencies, one of them is to make sure you're up to date with your annual BLS and anaphylaxis training. And within the travel health documents, there are signposting towards safeguarding, FGM courses. There's so much peripheral stuff here. But these are a really good baseline place to start when you have just started out in immunisation. So this next case is Sophia, HCA. She's just finished a 2-day immunisation course. The very next day, she's a fully booked influenza clinic all to herself. She's pretty terrified because she's not had any experience under supervision and no one has ever assessed her vaccine technique on a real person, only on a simulation on the course. She's only ever seen one injection being given in her life. She's told by her employer that all is required is the 2-day course, and the course must be pretty poor if she doesn't come out of it a fully fledged vaccinator. This is a criticism that IMS tutors across the land struggle with. It's a really common scenario. People thinking, I've done a course now, I must be an expert in it. And the same with employers who look at staff they've sent on training. The expectation really should be that this is just the start of the whole process and that training should continue when you get back into practice. This HCA should have support after a course and mentorship and helping to sign through the competencies and things. And it always surprises me, on nearly every course I teach, there's somebody sat there who looks terrified because they've got a fully booked clinic all to themselves the very next day. And this really shouldn't be happening, but it's surprising how much it does. Here's another case. So John completed his 2-day foundation training recently, and his mentor told him he needed 10 sign-offs and then he could do it alone. John has had 9 sign-offs so far and he's still not feeling very confident, but his mentor tells him to just get on with it. It should be enough for anybody performing vaccination to be deemed competent. In the national minimum standards, there is no number of times you should be watched performing vaccinations or anything like that. There's deliberately no number. And this is because everybody learns differently. In this situation, the practice has put an arbitrary number on it. They've said this is what we expect of our staff, and they're going to have to just go and do it afterwards. Now, a good mentor would go off piste from any arbitrary numbers here, and they would support John. They would look at the issues as to why he might not be feeling confident yet, and they would offer him a nice supportive learning environment in an ideal world. Everybody is different as to how quickly they feel competent at something. So this is a slightly better case than the one just before it. There is an attempt here to continue the training after an official course, but it's still not quite good enough, and you've got to be very careful when you put numbers on things, especially when it comes to training. It's done when it's done, you know. It's like the annoying people who pass the driving test after 6 lessons and you're there still on your 400th one and nowhere near passing. Everybody's different, and we should account for that in our practices. So here's another case related to competencies. HCA Sharon has been asked to sign off fellow HCA Rebecca for her immunisation competencies. Rebecca's just done the 2-day training. There are no other staff free to mentor her. The PM, the practice manager, sees Sharon as very competent, and he tells Rebecca she'll be in good hands. And I've no doubt that Rebecca will be in good hands. There's some really incredibly talented and experienced HCAs out there. Not a criticism whatsoever on HCAs. However, this is quite a responsible position to be involved in signing somebody off as competent, and this is specified in the minimum standards document as being this should be a registered member of staff who's doing that part. But there is nothing wrong with having a really supportive learning environment at work where you do peer-to-peer observations and help each other out, and I'm all for a really flourishing learning environment where people learn from each other, especially those in the same roles. But ultimately, the guidance suggests that the sign-offs should be done by a registrant. I've been talking a lot about the national minimum standards. These are the 2 documents I'm referring to, and one is for healthcare support workers, the other one is for registered healthcare practitioners. And within these documents it sets out clearly what somebody in each of those categories would be expected to do when it came to immunisation. And again, the key differences all seem to lie around assessment of patients. And of course, for a registrant, there are a lot more competencies than for the healthcare support workers, but there's also a lot of similarities, because remember, the task of giving an injection is exactly the same. It's what comes before and possibly after that is the issue here. I just want to direct you to one word that appears 3 times on this slide, and that word is minimum. As I've already said, everyone's going to be different in their approach to learning and how fast they learn, and they're also going to be different in terms of their attention on courses. So in the minimum standards, the recommendation is that someone completes a 2-day foundation course at minimum before they start embarking on their immunisation journey. Now, from being a tutor on immunisation courses, I see all the time that life is just going on in the background. You know, it could be a Zoom course and somebody's got a poorly child sat on their knee, or a dog licking their face the whole time. That happens quite a lot. Or somebody's maybe turned up and the course, but they're very unwell and they're not really focusing as much as they normally would because they've got a banging headache. In fact, for this reason, I always bring strepsils to every face-to-face course, because there's always someone who looks like they need a throat lozenge. So your best laid plans and all that, you can't always be 100% on the day of your training. Neither can the tutor. We have our off days too. And this is a problem when you're relying on that 2-day course as your training. That's your training done. So we should really pay attention to that word minimum and aim to support staff as much as possible, especially if they had a bad day on the day of the training and things like that. There's all sorts going on in the background all of the time. There's also, incidentally, a minimum requirement for a 2-day course in travel health if you are doing travel health services. And while we're on travel health, this is another case. Jonah is a registered nurse who has recently completed foundation training in immunisation and has been vaccinating on the childhood programme for a few months now. He decides to add travel health to the repertoire without doing any further training because he knows how to give an injection. And he starts administering hepatitis A and typhoid vaccinations to all the travellers. So I've already emphasised that he really does, well, it is recommended that he do a 2-day course in travel health before doing this. It's not just about the injections and being able to give one. And it's a really, really common misconception that travel health is just about vaccines alone. It's certainly not just about the vaccines. This is just the tip of the iceberg. And also the thing about travel health is it's not a very prescriptive or generalised approach. It very much involves so much risk assessment of the individual traveller and what they're doing and where they're going. And there's just so many nuances in travel health. Out of all of the vaccine settings, it's probably the one that requires the most clinical judgment and autonomous decision making. So he really just needs to do a course, and even a 2-day course is very hard to fit in everything that should be recommended. And same with the immunisation courses, there's so much to cover, there's so much information, and it really is just start of the journey. Here's another scenario that does pop up from time to time, particularly on update courses. So this is Jean. She's been working for the same practice for 35 years. She's never had a formal immunisation course and learned on the job mainly. She never signed any competencies and no such thing existed when she trained up. In those days, you just learned on the job, see one, do one, teach one. She's regularly seen to be doing outdated practices such as darting, aspirating, rubbing muscles post-vaccination, and not changing up needles after drawing up vaccines, which at the moment the only exception to that would be COVID, because the NHS provided needles syringes with needles attached, and you couldn't change them. You had to use the same ones that you were using for drawing up. But generally that's the exception, not the rule. So in Jean's case, she could probably do an update course and would probably get quite nicely up to date from that, providing she was willing to learn. And that would probably be a suitable approach, although there's absolutely no harm in doing a foundation course. The national minimum standards, though, they do suggest for experienced immunisers like Jean that an update course would be an appropriate thing to do, and as long as she fulfills all of those competencies, that's the main thing. She's doing the things she should be doing, and she could probably sign off quite a lot of competencies already. She just needs a bit of updating, really. The other thing about this is if her colleagues have been seeing her do these practices, I would question what's going on there. Why is nobody supporting her and offering her a bit of help and guidance? Are the rest of the team out of date as well, or are they just a bit afraid to challenge somebody on their practice? And of course, when you're on a register and you're following a code of conduct, one of the primary aims is to protect people and preserve safety, and not saying anything when you see an outdated practice like this is not really within the code of conduct. So I would also think about her colleagues here and whether somebody's seen these things going on and not done anything. Always know your whistleblowing policies as well, depending on what kind of context this appears in. So that's Jean. Jean should probably be doing some training. I've talked a lot about nurses so far. I'm very conscious of that. When I talk about codes of conduct, I'm also referring to ones that other professionals go by as well, of course. And here's an example of another professional and also a slightly different scenario where somebody doesn't have prior experience. So this is Antonio. He's a pharmacist. He's raring to go with adding a vaccination service to the business, which I'm really happy to see loads of pharmacists on courses at the minute. It's really nice that they are getting involved. he feels confident that injecting someone is fairly straightforward, so he watches some YouTube videos, signs up to do an IMS update course because it's cheaper and less time consuming than the foundation training. He has no access to supervision but decides, how hard can it be? So Antonio here is a new vaccinator, and the national minimum standards do say that anybody new to immunisation really should be doing a 2-day minimum training course, and of course access to supervision, which we've already discussed. So this is quite a tricky position for Antonio, but it's not uncommon that people don't want to give up 2 days to go and do a training course. It does seem more appealing when there's a much shorter half-day update or something like that, but it's very counterproductive to skimp on training, and the ultimate example of why is coming up next. And here it is. So I haven't specified which type of health professional this is because it applies to any one of us. We're all accountable to the law, and for patient safety, we're all there in paramount roles to protect them. So Katie has been vaccinating for years. She's just given a vaccine that resulted in an anaphylaxis, albeit this is a very low risk medicine to give somebody for anaphylaxis, but we've always got to be prepared for it happening. Sadly, her patient died. Katie had not done any BLS training for 3 years, and she failed to administer adrenaline or raise the alarm promptly. She just panicked. So just to put this into context, only 1% of cases of anaphylaxis admitted to hospital actually die. So this is a situation where she could have saved the patient's life, and her lack of training and competence here could have resulted in this patient dying, sadly. So here's the question I get sometimes. Can I give my injection still if my basic life support is out of date by a day? The recommendation is that we do annual BLS updates. The Resource Council actually say it should be anywhere between 3 months and a year. They don't say, well, we have to do it bang on a year. They say if you need to do it earlier, do it earlier. The key thing here is, does that person feel competent to deal with an emergency situation if it arises? It's not the law to do a BLS course annually. It's just guidance, it's just recommendation, but it's a very sensible one for sure. And it only really becomes a legal issue once something bad happens like this. So if Katie's standing in a court of law trying to justify why she didn't do her training as recommended, that's when it can become a real issue. She hasn't done her training, and the recommendation is to be annual. So this brings us right back to that course title of, should I be doing this, or can I give this medication now I've done the training? How to answer those things is very difficult, because you don't know necessarily how much somebody's taken in, how prepared they would be in a situation like this. This has to have some responsibility on the person doing the course to take ownership of that and be responsible for deciding how they would feel in a situation. And this brings us back to Martin's situation again that we mentioned earlier, where he was going off site on his own. How do people feel about the situation of if things go wrong? Not can they do it, but can they do things if something goes wrong as well? We should always be prepared for this eventuality. And that's why it's much more difficult to give when somebody says, well, if I've not done my BLS and for a year and a half, it's not a legal thing, it's a recommendation that they do it sooner. But if they feel incompetent and everything, and they could justify their actions if something happened, they'd have a lot more legal standing, I suppose, than if they didn't. On to the most exciting bit of the course. We've already had a little bit of excitement there with talking about anaphylaxis in emergency situations, but this is a really topical area. Healthcare professionals are in a really significant authority on vaccines, and people tend to listen to them in relation to vaccines even more than politicians, celebrities and other influential figures. I mean, look at Andrew Wakefield, for example. If you haven't heard of him, just do a quick Google and you'll see lots popping up about him discrediting the MMR vaccine, the links with autism. He was a doctor that got struck off. And it's the impact of the things he has put out there to do with vaccines has just the ripples have been going for years. He's the reason now why you're probably running about in your clinics wildly trying to read measles guidance. There's still an impact of low vaccine uptake because of this chap. So when a health professional is negative, people really do take note. And it's important to note that if you do advise something against medical advice, you should really be documenting that, because that will have been influential to that patient. And again, you must be prepared to justify yourself if things go wrong. Let's say you casually mentioned to a parent that you didn't want to vaccinate your child, so you didn't fill the consent form in for the flu vaccines at school. And let's say that parent goes away and decides, well, that healthcare professional didn't want to have the vaccines for the child, so I'm not going to either. And then that patient's child dies of flu. Again, I'm being very dramatic. I like a good dramatic case study, but we should always think, what if? What could this lead to? Then again, we're back in that court of law with the questions on us as to why did we advise against medical advice? We influenced that person. So hopefully, if you've done proper training, you'll be giving really accurate advice and you'll be nice and positive about vaccines, because learning about them really makes you realise exactly how amazing these medications are. This is why we don't just cover on courses how to give an injection or how to stick something in someone's arm. Yes, that's part of it, but it's a really small part of it. Ultimately, what we're training people to do is be able to talk about vaccinations with good information sources, with positivity, and with a balanced view. So of course we talk about the negatives too. We talk about side effects, we talk about things that could happen and the ensuing achy arm and a few days of headache that might happen. And we talk about these things, we do. And but in a balanced way, and nearly always the risk of a vaccine is far less than the risk of the disease that it's trying to prevent. Let's now look at an example of a registered health professional who blurred these boundaries quite a lot. But before I do, let me just point out some of the background to this case. So, because of the rise of lots of people using social media to express their opinions, which is absolutely fine, the NMC have sort of gone, yeah, let's look at this, because we don't just talk about vaccines in work, we talk about them in all areas of our lives. And people do make comments on social media and things. So the NMC have recently updated their guidance on freedom of expression and fitness to practice, because there have been a lot of health professionals struck off the register or disciplined because of the way they conduct themselves, both inside and outside of work. It's really worth having a good read of these things and being aware of how you conduct yourself outside of work as well. This is a really topical area. And as I said before, hopefully if you're well trained, you will have a really positive attitude. And that's why we cover more than just vaccines on courses. And we look at the diseases themselves and the positive impacts of the vaccine programs. In this particular document on freedom of expression and fitness to practice, there's an example given of a registered nurse who has done a public tweet saying that medical professionals who deliver vaccines are angels of death, and talking about that vaccination is just a plan to kill off the elderly. And the NMC comment on that as something they would intervene with. They would take regulatory action against that professional. And they go on to say in this document that we've got to be aware of how our behaviour can affect and influence the behaviour of patients, and we can't undermine public confidence in that registered profession either. The language used in that particular example is inflammatory, abusive, the speech is public, and it goes far beyond a reasoned debate on the pros and cons of vaccination. So let's look at somebody now who was not following the code of conduct here in this case. So this is Kate Shemirani. I can never pronounce her name. Shemirani. This is Kate. She was a midwife before she got struck off for reasons you'll find out shortly, and she was a prescriber as well. Kate still regularly posts negative comments about COVID vaccines on her Facebook page. She's got a very active YouTube channel. She encourages people not to have COVID vaccines. She states that COVID isn't even real and doesn't exist. She's very publicly voiced her distrust of the vaccines in radio and TV interviews, and actively has been involved in anti-vaccine COVID denier protests and acted as a spokesperson for the cause whilst using her midwife status as extra leverage. This is particularly serious in the eyes of the NMC because she's really discrediting the profession here. And the NMC don't look to regulate what professionals on the register say. They're allowed to express their beliefs and things, but they do take action when the belief means that there may be a risk to the public as a consequence. So they look at how publicly people are saying things, and also when there's a risk to denting public confidence in the profession as well. So we should always be guided by our codes of conduct if you're working to one, but even if not, we should be very responsible in this area. And whilst we do have freedom of speech, which is awesome, we do have to bear that in mind, that we are advocates for vaccines. We represent the medical profession, whatever role you're in. So it's really important to give accurate and balanced views about things. And again, this is where education is the cornerstone of it. If you have educated yourself in the right ways, using the right resources and not Facebook and YouTube, then generally speaking, you're going to be coming out of it feeling pretty positive about vaccines. They are very much amazing things. Let's have a quick look at a quick excerpt. We'll look at Kate in real life, some of the things she has been doing and saying as a midwife. I hope you cringe a lot while you watch this.
A vaccine may be with us, but it comes with a flare-up in the age-old struggle with anti-vaxxers, whose damaging narratives appear to be growing in strength.
No vaccine's ever been proven safe, and no vaccine has ever been proven effective.
We know that's not true.
Please allow me to answer your
Millions
question.
and millions of lives have been saved by vaccines.
Simply
They're some
not
of the
true.
safest medicines ever invented. That's just nonsense.
Kate Shemarani's emerged as a spokesperson for the extreme movement, spreading falsehoods about vaccination. And despite nearly 1.5 million deaths worldwide, she even claims there's no health crisis.
There is no evidence that I can see that a pandemic exists. There is no evidence that SARS-CoV-2 has been purified and is unequivocally in existence.
It is easy to dismiss such views, as the Prime Minister has done.
Because there's all these anti-vaxxers now, isn't it?
Well, Marina can tell you a little bit about how...
So I imagine you had a little chuckle as well at what Boris Johnson had to say about anti-vaxxers. Anyway, hopefully that horrified you a little bit, and I hope nobody who's watching this is saying things like this. I'm sure you're not. I'm sure you're not. She was a very extreme example. But this just goes to show that the NMC is there and will absolutely step in if stuff like this is happening. It is quite horrifying how misinformed people can be sometimes, including health professionals. That's the scary thing. And wonder how many people she's influenced. It does worry me. Anyway, the whole process of consent itself is about information first. And when we do our consent training, which I'm sure you've all done as mandatory training, we get taught an awful lot of things about like what implied consent is, like say when somebody takes their arm out of their sleeve and offers it up for an injection, we take that as implied consent, and they don't necessarily have to be signing stuff, and you know, as long as we documented that we gained consent, it can be verbal. And we look at all the ins and outs of parental consent and Gillick competency and all of that. But we mustn't forget, this isn't about just getting consent to stab someone in the arm. The informed part of it is very, very important, and it often gets missed out. Surprising how much it gets missed out, that informed bit. And the Green Book chapter, of course, is our national policy on consent and was updated in October last year. So if you've not read it for a while or you need a refresher, it's probably worth having a good read of that. So the main updates were around off-label and unlicensed administrations there of vaccines. But that's a good place to start with consent. The cases that I'm about to show you next are in relation to little nuances around consent, things that perhaps won't be covered on like a mandatory training course as much. So they're just some examples to try and illustrate some points about consent there. A lot more subtly than sometimes you get taught. Here is Annika, the practice nurse. She sees a patient who's about to go on holiday for a travel health consultation. She reviews a pre-travel risk assessment form in conjunction with Travel Health Pro and then books the patient in for an appointment. All good so far. She's used evidence-based practice there. She's used a really good platform for helping make clinical decisions about travel risk. However, it all falls down in the next bit. She tells them they need 3 injections and administers a vaccine, typhim and Rivaxis, that's hepatitis A, typhoid and tetanus, diphtheria, polio, without letting the patient know what they've agreed to or why the vaccines were recommended. This is a situation where a patient might well hold out their arm and say, yes, I'm happy to have these vaccines, but they have no idea what they're agreeing to. I was this person. I used to do a lot of travelling, and I remember going to my GP to get travel vaccines before I was a nurse, a long time before I was a nurse and I knew anything about travel health. And I remember being jabbed with something, not knowing what it was, and not having any travel health advice whatsoever about these diseases. I walked away feeling invincible. I thought, great, I've had my travel jab. I'm going to be fine on my trip for everything. And this isn't an uncommon perception by travellers. There are more out there like me, I must say. So there's more to consent than just someone agreeing to having a vaccine. And this is why, again, we cover diseases as well as vaccines when we do the course. If it was just about giving a medication, we wouldn't need to talk about the disease, but it's not. We need people to be discussing these things and also notifying patients that vaccines are a second line of defence. There's a whole load of things we can do other than vaccines to help prevent get diseases too. So advice needs to be provided about avoiding the diseases in other ways and diseases that are spread the same way but don't have vaccines available for them. Hepatitis A is a good example there, spread through the fecal-oral routes, which many diseases are spread that way. And we only have the vaccine for hepatitis A there, but they could be many other things that the patient could get through not taking the right precautions. Plus, few vaccines are 100% effective. That's another consideration here. Here's another example, again, a travel health client. They come into a private travel clinic, wants to have a vaccine for visa purposes. He states very clearly he doesn't want to know anything about it, hates vaccines and doesn't think they work, but will have it anyway for the visa. He asks the nurse not to tell him anything about it and to just get on with it. And the nurse obliges. Now, this situation really is not good enough on the part of the nurse. Firstly, you don't want patients thinking that vaccines don't work, so we've got some misinformation to correct here first. On top of that, this patient does need to know about the medication they're having. They need to know side effects, what do they expect after having the vaccine. They also, in this context, would need to know about why is this a visa requirement? Is this a contagious disease? Are there other precautions they need to take? For instance, it could be meningitis. A meningococcal vaccine for entry to a country where they're going to a place where there's like a mass gathering or something like that. So advice around that is also very important. And on top of that, if they're travelling, there's probably other vaccines they need to consider as well. So this should have been a much more thorough consultation, challenging misinformation and also looking for other things that are missing. And this is where a lot of clinical judgment comes in with travel health. This type of situation also happens a lot with needle phobia, where people are either too anxious to take everything in, or they tell you they don't want to know anything because they're anxious and they just want to get it over with. And I think it's very important how we consider what information we're getting across to people and are we doing it in the most effective way. So this is our last case on the course that we're going to be looking at. So Matteo is a school nurse and he's just received a complaint from a parent that was shocked to find out that their child had the nasal flu vaccine and that it contained porcine gelatin. They'd signed the consent form, but they hadn't realised what type of vaccine it was. They thought it was an injectable one. And this is a case now where Matteo is dealing with a complaint from somebody who's unsatisfied, who's consented to something they didn't realise what they were consenting to. So this is as much about vaccine uptake as it is informed consent. And we really do need to consider the information that patients have about these vaccines. So there's loads of really useful government resources. There's brilliant websites that are government supported, like the Vaccine Knowledge Project. I refer to that an awful lot, and I get people accessing it on courses as well. It's wonderful, all based on the Green Book as well. So we know it's a good resource. There's a real example mentioned in the National Vaccination Strategy document that I mentioned right at the beginning of the course. It's a case study and it's to do with the HPV, polio, tetanus school vaccinations in Trafford, just around the corner from me. I'm based in Manchester. You can probably tell from my accent, even though I do put my posh voice on for teaching. Anyway, this happened just around the corner. So they noticed that they were getting really low numbers of consent forms back for these vaccines from parents. They quoted the statistics 30 out of 170, which is 17% came back. And so they followed up with a nudge call to the parents, and they listened to what the parents were saying about why they hadn't sent the consent forms back. What they noticed was that firstly, the parents weren't aware of what these diseases were all about and what the vaccines were actually for. And they also noticed there was big language barriers, that many of the families in this catchment area were speaking Urdu, Punjabi and Farsi. So to tackle this, the teams decided to attend a parents' evening at the school. And they gave information and they gave out consent forms there too. And they put posters up in different languages. They even brought an interpreter with them who could help explain things to parents. They were on hand the whole time. So because they did this, on that night, they got 47 consent forms completed that very night, which was amazing. And this approach is now going to be replicated in other schools in Trafford. And it's a really good example of how to give information appropriately and increase uptake at the same time. So this brings us towards the end of the course now, and thank you so much for your attention throughout. Here's my key message to you. We've got this new vaccination strategy and lots of exciting proposals for expanding the workforce and expanding people's roles and that kind of thing. But whatever changes that come along, we must always remember the things I've discussed here, the duty of care, the rationale for our practice, and always act in the best interest of the public. They are trusting us to do our jobs professionally and safely without pushing the boundaries of our roles or putting them at risk in any way. As I said at the beginning, probably one of the most common questions I get will start with, can I give, or can I do this now, or should I be doing this, which is of course the title of the course. And just a reminder, anybody can do anything as long as they are willing to go to court for it if it goes wrong. The tasks we do, they're all the same task. It's everything that leads up to those tasks and that administration of a vaccine that is not, and sometimes afterwards too, like with anaphylaxis. So I hope that's the key message you'll take from this course. I've just got a couple more things to let you know about. Firstly, we have a really good blog area on the Health Academy website. I'd strongly recommend you have a look at them. There's some popping up on the screen now that are relevant to this title of this course, legal and professional issues. And we all love writing down our thoughts and on things. I recently wrote one about whether nurses can work alone in a vaccination setting without a doctor on site, which you're welcome to have a look at. Michelle churns out blogs. She's amazing. And Ewan, who's one of the directors, and Neil, they also write things as well. And there's loads of different blogs. And yeah, go and have a look at that bit of the site. And finally, we also have loads of courses. So if doing this course has made you think, maybe it's time for an update or some foundation training, and I hope to see you on them, you could sign up for a course. We have loads of different options. We have face-to-face options for those who like a good old natter at the coffee machine on the breaks. We've got Zoom options for those who kind of want to keep their pajamas on and stay in bed for the day, which is absolutely fine. And we've also got e-learning courses as well for people who really don't want any social contact on a course. So whatever your learning style, whatever your preferred method, we do have a course for you. We do lots of updates and foundation training in all of the things I've been discussing and more. So do check them out, and I hope to meet you on a course someday. Thank you again for your attention, and I will see you on the next free webinar. Bye.